Another entity when we talk about so-called secondary HFpEFs is the hypertrophic obstructive or non-obstructive cardiomyopathy. In this case, we also have a thickening of the ventricle, so a thickening of the myocardium, which is true left ventricular hypertrophy, and we can see it over here. This is the interventricular septum, and this is the region where we have the thickest walls in this four-chamber view, so the lateral wall is not that thick, at least what we can see. We can even delineate it better with contrast agent, and we see that truly this is a septal hypertrophic cardiomyopathy. But from these images, as we can see, there is no obstruction present. The lateral wall, and here in the apex as well, is definitely not severely hypertrophied, whereas the septum is truly thickened and hypertrophied. Here we can also use strain imaging to help differentiate how longitudinal function truly is. Systolic longitudinal function. It's overall the most common genetic heart disease, so in case of a thickened hypertrophied ventricle, you have to think about hypertrophic cardiomyopathy. Even healthy individuals, or before it was obvious or evaluated that they actually have hypertrophic cardiomyopathy, they were considered healthy. They can suffer from a sudden cardiac death. We have here no increased afterload, so we should not see a relevant aortic stenosis, and we shouldn't have, of course, severe uncontrolled hypertension. And we have this true form of left ventricular hypertrophy. And here in this strain imaging, in this bullseye display, you see the inferolateral and inferior and lateral regions are contracting quite nicely. When we look at the septal regions, the strain is reduced. So in hypertrophic cardiomyopathy or in hypertrophy, the region where the heart or the left ventricle is hypertrophied the most will normally have the most severe reduction in strain imaging. We can see here this quite interesting phenomenon. Again, here the machine thinks that this, due to this hypertrophy, is even a dyskinetic motion of the heart, which in fact is simply this hypokinetic longitudinal function of the ventricle with this severe hypertrophy. Here we have a case with the MRI with left ventricular hypertrophy. You can see quite nicely that the lateral regions, they are not really hypertrophied, but the septal portions of the ventricle, they are truly severely hypertrophied. And these patients, they can suffer from dyspnea, but they can also have a syncope. They can suffer from VTAC, and as I said, sudden cardiac death is a topic, especially also in young and before the diagnosis of hypertrophic cardiomyopathy, healthy individuals. Think about in athletes about hypertrophic cardiomyopathy, because it's a common cause for sudden cardiac death in young athletes as well. What can we do? Well, so far we can give beta blockers or calcium antagonists, especially here verapamil, for hypertrophic obstructive cardiomyopathy to reduce the gradient in the LVOT as we see it here. We also see it here quite nicely. This is a case of an hypertrophic obstructive cardiomyopathy. You see the thickening of the septum, the posterior and the anterior mitral valve leaflet. This is the aortic valve, and during systole, the anterior mitral valve leaflet is pulled towards the thickened interventricular septum. This is a so-called SAM phenomenon. So a systolic anterior movement or motion of the anterior mitral valve leaflet, which causes an LVOT obstruction or possible LVOT obstruction, and also possibly mitral regurgitation. You can see it with contrast that truly the LVOT gets blocked by the anterior mitral valve leaflet, so this SAM phenomenon. The good news is that there's a so-called new kid on the block, mavacamten. It's a cardiac myosin inhibitor, and it has very promising results and shows or treats patients with hypertrophic obstructive cardiomyopathy with a reduction of actin-myosin cross bridges. Due to that, the hypertrophy can be reduced and also the gradients can be reduced, so we do not necessarily need surgical treatment. And overall, we have to mention that beta blockers and verapamil, very often they are not well tolerated by patients who have hypertrophic obstructive cardiomyopathy. So I'm very curious to find out more about mavacamten and how it actually works. In mavacamten, what we know so far is that it works quite nicely, but we have to evaluate ongoing left ventricular ejection fraction to not oversee that ejection fraction over time is reduced as a side effect. Here's the example again with strain imaging. We do see that this portion of the ventricle where it's severely hypertrophied, now we just measured this specific part, is the most reduced. We do see again somewhat of an apical gradient, but the lateral portions and the inferolateral portions, they are still contracting normally, but the most thickened parts, the septal parts, so the basal and the mid segments of the left ventricle or the interventricular septum, they show the least longitudinal function, the least contraction. Here we can see the strain curves, and we do see that this basal segment shows here quite nicely the most reduction, and also practically no longitudinal function is present. But be aware here, the optimum measurement would have included the entire thickness of the septum. I want to show you this hypertrophic obstructive cardiomyopathy also with a cine loop in MRI, and we can very nicely see in this a little bit oblique four-chamber view that there are several things we also already saw on the echo as well. We do see that the septum is the part which is mostly hypertrophied. We do see that there is this SAM, this systolic anterior motion, and we do have here a flow turbulence. Even we see it on MR in the LVOT, so this LVOT obstruction and this SAM phenomenon. And we also see here a flow through the mitral valve in systole, which is mitral regurgitation. So these patients, of course, need an MRI to quantify the risk and to see if they are more likely to have a possibility of sudden cardiac death. But it also shows very nicely how we can compare two imaging modalities. So echocardiography and MRI, especially in these cine loops, you can compare the images and the findings quite nicely. But this will also be a topic when we discuss left ventricular hypertrophy and the thickened left ventricular walls.